Thank you, Jerry. It's good to be here. I'd like to take you on a little walk through a genetics clinic on an average day. This is a child who sits in your outpatient area, and it's not very easy dealing with patients who indulge in poking their eyes, as you see this little child in the picture. It signifies that the child might have very poor vision, often seen even with very extreme cases of ROP, and as in this case, a disease that I've studied many years now. The mother presented saying that the child is not looking at her face, and this is very disappointing for a mother because she longs for the moment to look at the child's face and smile and interact with the baby. These children often present with photophobia, photo attraction sometimes, night blindness, and their fundi sometimes might look absolutely normal. And it's also very difficult to photograph, fundus pictures in babies. And that picture was taken when the child was quite young. If you look very carefully, as the child grows older, you'll notice that they have nystagmus, strabismus. They can even present with poor pupillary reflexes. Optic nerve pallor has been noticed. Progressively, they can have blood vessel attenuation, and their retina can range from the normal to even frank pigmentary bone spicules as time goes by. Their refractive errors are quite commonly hypermetropic other than myopic. This disease has been talked about quite a lot in recent times, and the reason we present this as part of the genetics course and for doctors to identify this disease is so that we'll be able to treat patients with these rarer forms of disease. So Labour very fortunately described this disease quite a long time ago as presenting in infancy and also as genetically and clinically heterogeneous. They present also with poor ERGs, and quite often you might have to repeat the ERG to have a very sure diagnosis, because it's quite an awful diagnosis to give to a mother or a family, because these patients don't perform very well visually. The incidence is about 1 in 3 in 100,000. It is more increased in populations where people marry consanguineously, as quite often seen in Saudi Arabia or even in South India. It accounts for only 5% of inherited retinal dystrophies, and we have quite a large number of genes identifiable in this condition now, even from the time that I started working on this condition more than 10 years ago. Interestingly, this is also a condition which, earlier Jerry talked about, where you inherit a little bit more from a mom or a dad, as you see in uniparental disomy, as you see in RP65 related association of this particular disease. And you also have syndromic and non-syndromic forms of LCA. Here's a 10-year-old child that I met in South India. He's born to consanguineous parents. The mother wasn't given the proper diagnosis in the first child, so she now has 3 children with the same condition because she was told that she perhaps had some infected TORCH-related condition. So it was a very devastating diagnosis for this family, whose father is a police officer, and he was hoping at least one of his children would grow up to be a policeman. The other findings that you notice in families with this condition is that they can often present with keratoconus, cataracts, and ophthalmos, quite often acquired from progressively rubbing their eyes. When patients present with this condition, it's bad enough they have an eye condition, but it is currently our duty to make sure as ophthalmologists that they don't have any associated findings on a systemic level which might endanger their lives. Joubert syndrome, which is associated with neurological problems, Saldinomansia, and senior locum, which involves having a kidney transplant because they have nephrolithisis. It's very important to sort this out because you could save the child's life. Mutations are now, predicted to happen in more than 20 genes that we have identified that is closely linked with this condition. And all of them perform a different function. So a tiny change in a tiny sequence, even on a retinoid metabolism cycle can involve blindness, as you will see. But the better part of understanding this disease is being able to find ways of treating it. So it's better documented. We see phenotypes, and we tend to understand how big these genes are, how promoters and enhancers make the phenotype change, and also give us some history of the progression of this disease. and we understand better the natural history of this disease, because as you notice, a lot of retinal function is involved, and each of these genes perform a different function. The phototransduction cycle gene, GUCY2D, was the first gene that was identified in 1996. We've certainly come a long way in a very short time. So, and 11-cis retinol, the gene which is involved, causing LCA due to an RP65 mutation, is the one that has reached therapy at the end of about 15 years. So there are good stories to take away, because all we want is for our rods and cones to be better. This is a quick picture quite similar to what Chitra talked about earlier, telling us that as time goes on, we have a better understanding and a better mutation detection rate, because we are able to understand genes a lot better. And the frequency of mutations in different populations tends to vary. And all these genes are often known to cause other closely related retinal diseases like rod-cone disease or RP as well. And so we look at retinal disease a little differently now. We look at it as a spectrum. The worst form being LCA, smaller versions or lesser affected forms being cone rod dystrophies. So we can call an animal by different names, but it has a bit of everything in it. Here's an LCA phenotype, pictures of the retina from patients who have, from a colleague, which shows pictures where different genes have been affected. And you notice some of them, there are very subtle changes. So when a patient presents in your clinic, there are some clues, as you see here, as to what gene could be mutated in this individual, and you could start with screening that particular gene as you see here. Sometimes it's easy and sometimes it's not. Perhaps CRP1, which has nummular pigmentation, and RP-GRIP1, as you see here, may be good examples. My own journey through this disease also took a long time, took place a long time ago. In South India, we have large consanguineous families, and this is an Amish Mennonite family who migrated from the Swiss part of Germanic Switzerland, basically, and they migrated to Pennsylvania. There's a large population of these Mennonites in the US, and I studied one such child. Here you see my prof and the nurse drawing blood from a family that we visited. They have exceedingly good family pedigree records, and that's a picture of the child that you saw earlier, who presented quite normally, but by the time she was 20, she was performing quite poorly. And the little dark rods that you see are the last generation of the family that I studied. And it involved having the last child to make out which particular gene was affected in this family. And we managed to localize it to chromosome 6, where the labour protein was not functioning very well. This is a ciliary, it's part of the cilium. So the tiny cilium connecting the outer and the inner segments is all that was wrong in this family. So ciliogenesis has become very important in days to come, both in the medical world. So we now study things differently. We call it ciliopathies, or we call it channelopathies, as you will see sometimes in epilepsy-related conditions. So the cilia has become important, and we even have clinics which are called ciliary clinics, where people gather from different specialties, because the cilia is found in different organs. So in our case, for LCA alone, we're looking at RP-GRIP, CEP290, and labercillin, which is the disease that I study a lot. But since cilia are found in many organs, you can also notice that other organs are related, as in CEP290, as you see that it maps here with problems in the neurological system. So you have neurologists, cardiologists, and in senior locum, you have patients with nephropathy. So you have the renal physicians and surgeons at these meetings. So patients are now treated with a multidisciplinary approach. Here's a picture of Joubert syndrome, which you see where patients present with cerebellar hypoplasia. You see a classic molar tooth appearance in the picture. So genetics has come a long way. We still need to understand modifiers and interactions, though. Sometimes we don't understand the clinical picture clearly because of polymorphisms which interact and perhaps change the picture, and also intronic and promoter changes and gene interactions. You've already understood a little bit of the chip technology. So if a patient presents in your clinic, perhaps the first thing you might do after documenting their natural history is to take a little bit of saliva or a cheek swab to be able to understand which, sort of run them on this chip to make out whether they have a known mutation of the LCA gene. Of course, that is one step nearer in understanding it. Because what happens is that we need to identify our phenotypes and genotypes more clearly for them to have more functional outcomes in time to come. So there are several models of LCA as you see here, and since all these creatures can now see, perhaps it's time that humans saw too. So human gene therapy has come to stay, and ophthalmology has made it possible to see how this works in a patient's eye. Currently there are 3 centers that have been involved in gene therapy, where you take a little bit of a functional gene and put it into patients who don't have a functioning gene, so that it turns on more function and the RPE65 and the retinal pigment epithelium in these patients, where we took an adeno-related virus, took off the toxic component from the adenovirus and injected it into the subretinal space. So this is one of our first patients, and he was really happy to be able to see, and he said that he could now see the blue sky. It's a very small thing to give back to our patients. So we hope in time to come we'll be able to treat all of LCA. Currently we're able to do only one. Perhaps there are trials for a couple more, and we finally see the light at the end of the tunnel, which is quite promising for us. Our next patient is a 7-month-old Jewish child who came in because the parents thought that the child, who was now 5 months, was retrogressing. She was quite happy, she looked fine, she looked normal, but now she was developing wandering eyes. So it's quite devastating for families to experience a normal child in the initial stage and then find that the child has become ill. So these patients present with an increased startled response, and sometimes their heads can be quite large. The sad thing about this is that in ophthalmology we don't really deal with death, and this condition often makes us make a diagnosis which is not a very grand one to give to parents either, because these patients get progressively blind and are not around into their 6th or 7th year. This is an autosomal recessive disease, and it runs in certain families. The population of people most studied were the Ashkenazi Jews, who came from Eastern Europe, and they have a carrier frequency which is about 1 in 25. So quite likely when these people meet other people from the same population group, they have a very high odds risk of having a child with this condition, and it is not as high in the normal population. So as you see, as ophthalmologists on a neonatal consult, you might be asked to see a child who's not performing so well neurologically, and you use your ophthalmoscope to look for a cherry red spot. It's all a grand thing to see when you're a resident, but it's a very sad thing to give this out as a diagnosis to a family, as you see in this picture, because these patients have nystagmus and they have decreased acuity as time goes on. Day and SAC were quite involved in making this understanding this disease, which is a deficiency in the hexa-A gene, and then there's deposition of gangliosides in the cells. So it's also seen in other subgroups of people, as you see here, and you see that there are these intercalated bodies that you see on electron microscopy in the neurological system in these patients. The important thing is to understand the family history of this condition. It's also been easy to diagnose because in the old days there was an inexpensive enzyme assay of the hexosaminidase gene that you could do. So patients were very switched on that this condition ran in certain families, and it was easy to make the diagnosis. So as you see here that the lysosomes that process these bodies are affected, and you can see that they are not able to process this body, leading to the accumulation of these gangliosides. You also have adult forms in this disease which are rarer. What are the treatment options for this condition? You have enzyme replacement therapy, gene therapy is being tried, and there's also some stem cell therapy, and there's manipulation going on. As you see in the pictures on the top and the bottom, one is untreated and the second one is treated. So you see there is some improvement. The more important thing is screening approaches and prenatal diagnosis. It's possible to have pre-implantation diagnosis in this disease, and you can have mate selection. And you can also be very switched on as whether you carry the gene or not. So very careful planning is what has led to success in controlling this condition at the present moment. So they say that in the Ashkenazi Jew population, it's very rare now to have a child born of this condition if lived in Israel, because they're all tested apparently as part of their prenatal screening. The third disease that we're looking at are refractive errors. As you see, nanophthalmos, which is basically a very small eye, both the anterior and posterior segments being small. The non-syndromic form is what you might see in your clinic when you refract and you notice a child has high hypermetropia. You've got to think twice if this is just an isolated case and what this is associated with, because you might have nasty surprises at surgery. You have autosomal dominant and recessive forms. The other one is syndromic nanophthalmos, which is rare. These are syndromes which you might see associated in your clinic. If you don't know, you don't look. But if you know, you look for these conditions. So it's important to look for things other than the eye, as you notice in these odd or adverse syndrome or the Kenny-Caffey syndrome. And very occasionally you will find patients with these problems. Interestingly, genes have been found for these conditions, all of which offer different roles in the life and function of the eye. And if you see these pictures, you notice that it's not that difficult to make the diagnosis. As you notice in the odd syndrome, you see that there's slight syndactyly. Currently, everybody has an operation, but if you look at the child's hands, you will notice that the parents will say she's had an operation earlier because she was being teased in school. The first picture is adverse. If ophthalmologists don't look at the periphery of the retina, you're not going to make this diagnosis, because it's the periphery of the retina that offers you a clue. The third is a Caffey syndrome child who also has nanophthalmos associated with other problems. This is a family that I studied a night who presented with a small eye, and the child couldn't see quite clearly. She was doing poorly. She had a hypermetropic power of about 20. That's the macula, very small eyes, very narrow angles. Glaucoma is a presenting feature. Sometimes you haven't made the diagnosis. And angle closure, very difficult to treat, and choroidal effusions and retinal detachment. But if you make the diagnosis, then you're prepared for what's ahead, and quite often some people remove the lens in these patients to help them see better. So this was a condition that we followed up in populations in the Mennonite world, and we were able to identify a gene for it. So nanophthalmos genes too are of, there are several of them, and there are only few that have been mapped, as you can see here. So these are non-syndromic nanophthalmos genes. There are 2 of them currently, as you see, and perhaps we will find more. A small eye, quite not so difficult to do if you do an OCT or an ultrasound, and if you examine the family and look at other members of the family, they may have retinal changes that makes them see poorly as well. And, offering a license to a child to drive with this condition is quite tricky, because you want to make sure that they have proper fields and they have better functioning vision. So managing these patients is possible, because you need to prevent amblyopia for them as children to make sure that they understand what's going on, and to also examine them serially and carefully. So it's a nasty surprise only if you haven't realized that the child has nanophthalmos and they're sitting on your cataract list. So careful planning can bring you success. So I want to acknowledge all my co-authors and colleagues who helped with this presentation. And I want to leave you with the fact that with genetics we do find cures for certain things, and we have to proceed onward, helping our patients to see a tad better. Thank you.